Welcome, welcome everybody. I am not sure, as always, with these webinars, what you're seeing and what I'm letting you look at. I'm going to hope that you're seeing me now, and I believe that's true. So we'll carry on. If someone can text me, if they know my number, I've got my phone with me, and we can proceed from there. So welcome everyone. My name is Jonathan DeMonte from Vancouver, Canada, where it's a beautiful spring day. And I'm here to talk about how to cheat time with Bowen therapy. And this is perhaps the third of the webinars. I think the last one wasn't successful. I have a lot to learn when it comes to setting up these webinars, the technical aspect. They're pretty complicated, and I've just spent quite a bit of time trying to set this up properly so that I can evolve my learning process and get a little bit better at presenting, some relevant information. So welcome, and no text so far, so I'll assume we're doing good. So the purpose of this seminar is really to give you some affirmation of how you're using Bowen therapy in clinical practice, and maybe it's going to enable you to feel more confident about the choices you've made and want to make around treatment plans for clients with specific issues. So we're going to look at some acute problems and some chronic problems and understand how we can, not just cheat time, but make time move faster for our clients, that they may get better more quickly. Okay, so I'm going to switch now to a presentation, and I'm hopeful that you're seeing that. And this should read in red letters, how to cheat time with Bowen therapy. And I'm looking for a text from anyone to see if this is presenting or not. And my hope is that it is, and that you're hearing me clearly. So to start with, we'll understand really what is the main idea of this webinar, and it's really to help people get better faster, not treat them faster. That's not necessarily the idea, but we want to get them on the right train of recovery. The momentum of that movement has to be really as quick as possible. That's our goal as therapists. Going to look a little bit at why some people get better quickly and others take longer, and we'll go through quite a few options of how to speed up the process of treatment and what we can do to improve that time frame of recovery. So in traditional Bowen therapy training, we're taught a very minimalist approach to the treatment plan. And I think a lot of us, live under a very dogmatic, rules-oriented approach to Bowen therapy. And that's not necessarily a bad thing, but, my goal is to help you, formulate other ideas that work for your clients rather than your ideas or your training. We learn that pauses are mandatory in the process of a Bowen therapy treatment, and we're going to discuss some of the ideas around that, whether they are or aren't mandatory, and what is their real purpose. And let's think more about that, perhaps. So in a traditional Bowen therapy standard procedure, this is the way it's taught mostly around the world, with most therapists and instructors teaching it this way. We do, on the left, you'll see a basic standard BRM1, and we can see here there are 8 moves. Moves 3 and 4 are repeated, and these become moves 9 and 10. And you can see after each set of moves, 1, 2, 3, 4, there's a pause of time. 5, 6, 7, 8, there's a pause of time. There'd also be a pause of time after the repeat of 3 and 4 as moves 9 and 10. Another pause. So there's 3 pauses in essence. And I think for most of my clients, when they come, they do receive this form of therapy as a kind of standard place to start. And in many ways, it helps me to understand what's going on with their body at what level they're responding to the treatment as well. So then follow with the upper back procedure, basic relaxation move 2, and we see that on the right. And we do 1, 2, 3, 4. There's another little clock symbol, meaning another pause. 5 to 8, another pause. Perhaps I'll be doing a repetition of those moves, along with the moves 8A and 8B of latissimus dorsi. But traditionally, we'll then do moves 9 to 16 and another pause. I've noted in this picture what are known as the stoppers, and at one time we were teaching that the stoppers had a lifespan of about 10-15 minutes, and we'd repeat them again. And that's something you could consider doing, but that's another set of moves that you would apply, where the bottom line of dots is demarking moves 1 and 2 of BRM1. They are the lower stoppers, and then the upper dotted line is demarking the upper stoppers, moves 1 and 2 of BRM2. So you can see there would be, if those stoppers were enacted and refreshed, so to speak, after 10 to 14 minutes, then you'd be doing a lot of moves. So let's think about how to simplify this and make it a more patient-friendly experience. So in thinking about the options, we can talk about acute and chronic types of conditions. And so an acute scenario would be a patient with a back that went out, a low back herniation, a bulging disc. It could be someone with a recent tendon or ligament injury, such as a groin strain in their adductor longus tendon at the pelvis or the gracilis, or it might be a tendonitis of their triceps or biceps. So general strain and general injury situations could be the acute story. This may be an acute episode of a chronic problem also. And then other scenario would be chronic stories where we see arthritis, both rheumatoid and osteo, fibromyalgia, chronic back pain, migraines, this sort of thing, where the chief complaints of the client have been ongoing and long-lasting. So these are really handled in many ways a little bit differently in how we manage the patients. So let's take an example of a back strain leading to sciatica. And a common protocol that I would use would be BRMs 1 and 2. I would strongly consider the Coxix if there is a one-sided spasm in the lumbar muscles. And you'll be able to understand if that's the case when you do any assessment, either moves 1 and 2 of BRM1, but especially you'll see it during moves 9 to 16 of BRM2 if you do that procedure. If there's a misalignment of the sacrum, i.e. in a fall or a sports injury, a twisting injury, we might see a misalignment of the sacrum and thereby the pelvis. Then I would most likely do the pelvic and sacrum procedures and not consider the Coxix. So that's a very symptom specific protocol where I've chosen to do either the Coxix or pelvis and sacrum, dependent on the type of symptoms they're expressing. And if the pains are extreme and the client improves only for a short time, I will have them return even as soon as the next day. So that means that I'm breaking the rule of 5 to 10 days in an extreme acute scenario where there's a significant sciatica. The benefit of that is that the client may improve for just a short period period of time following the treatment. And it's clear that they've relapsed, even in the space of 10 or 12 hours, or even a few more hours than that. And this gives us the chance to repeat the procedures necessary a second day, enforcing the structural change we need to, and giving them relief much sooner. If they're better, they won't come. It's as simple as that. I make it a tentative option. And this has been my practice for about the last year that I've been doing this, and I found it to be really very, very, very useful. Much better than waiting for long numbers of days where they're just frustrated because they got a little bit better and then a little bit worse. Now, when I do this, the hip and leg flexing are optional. I don't necessarily do them. So I hope that's clear and gives you an option of when and where to use these, very fundamental procedures for low back issues. And, understanding how and when to apply the pelvis and sacrum procedures in relationship to the Coxix procedure is tricky and, requires a bit of confidence in your decision-making process. So again, look for spasms in the lumbar region to choose Coxix, and pelvis and sacrum, you choose those based on misalignment of the sacrum. So often that's the person who's, hunched over to one side and clutching their low back, and, they're just twisted out of shape by all standards. So just quickly looking at the Coxix procedure, to remind everyone a few pointers about it. At a very, very minimum, you could just do a Coxix procedure in this sciatica type situation where the lumbar muscles are in spasm. And, you only need to do BRM 1, moves 1 and 2 as a minimum prerequisite, and apply the Coxix procedure. And one thing that I've learned over time is the right degree of pressure to apply on the Coxix is some effort is required to apply enough contact on your moving finger as it moves over the second coccygeal vertebrae, which is on most people is the largest bump of bone on the Coxix. And our finger needs to transverse from side to side, from one point to another, from the painful side to the non-painful side. And we need to maintain a fair bit of contact. Most of us don't have enough finger strength to do that effectively. And so I recommend to my students to use a pillow to bolster the leg. Or if that's awkward, don't even worry about the leg flex. The move is more important. And use a finger on a finger for the moving over the Coxix. And that enables you to press more firmly into the holding point at the inferior margin of the sacrum. So you've got enough pressure then to move over even the largest Coxix. Generally speaking, I'm doing it through clothing and having great success. So that's another aspect of saving time. Now on the opposite side, once we turn the client over, if they've got some restriction of movement in their low back and sacrum, and you feel they won't be able to tolerate bending of the hip, don't. Just do the moves over the rectus abdominis muscles, as you can see here in the move 2 picture. Okay, so pelvis and sacrum, just a quick look at that. Again, you can apply the moves without necessarily bending and flexing the legs of the hips in the pelvic procedure for move 4. So if you're only able to release the muscles, you've achieved a lot. You've achieved a lot. So in this picture, the leg is slightly opened, and you can see more clearly where the adductor longus is. And again, this is a move that really does require a softening of this large and strong tendon. Not necessarily a releasing of it, but a softening. And move 3 over sartorius is quite simple. And then the move over the inguinal ligament is also, most people find quite simple. Okay, and then the sacrum procedure. A couple of ways that we can apply this. And one of them I want to encourage everyone to try is to perform the procedure laying prone, especially in the story of someone with an acute low back injury, that to apply the moves with thumbs and fingers is not so difficult and is worth practicing. The sacrum procedure is a procedure that we use a lot in Bowen therapy. Anytime a client is still stiff, they've got a bit of immobility in the sacrum, after standing up at the end of any treatment, I will apply the sacrum procedure, and you'll see 9 times out of 10 that it is relieving that stiffness. Okay, so other things to consider are the types of conditions that are not so injury oriented. So we might have a person come with many different problems and health concerns. So here's a list of just as very typical clients' problems: diabetic neuropathy in the lower limbs. They may have migraines. They may have post-surgical nerve damage, degenerative hip disease, and in these conditions you might see other areas or joints where the body is affected. So how to manage this sort of problem would be, again, we may be addressing many different areas of concern. So we'll talk about ways we can use different procedures during the same session, even while treating these significant symptom stories. So there's always a way to address a few different concerns while maintaining a hierarchical approach to treating the most significant problem. In this scenario, we've got cases where the conditions are much more chronic, such as in rheumatoid arthritis, osteoarthritis, fibromyalgia, and here we see where, again, multiple areas of concern are common and needing to be attended to. Often these types of clients cannot even take enough. I mean, what I want to say is that coming for these clients for treatment is a big effort, whether it's time-wise, energy-wise, or oftentimes financial concerns are a factor. So these are the kind of clients that might come to see you and want you to do a whole shopping list of procedures. They've come as a client for a few successive treatments, and now they have to budget themselves and come with a list of complaints that they want you to address. And we have to find ways to manage the potential for aggravation when we do a lot of Bowen therapy. So this demonstrates a couple of ways that we can save time. That really refers to the treatment plans that I gave you for treating low back spasm and disc hernia. But always we want to use the most simple logic for the client, and the symptoms and the way the patient responds, even during the session, dictate the pace and the amount of treatment you can use. And so now we're going to look at some of the ideas for that and how we can use some shortcuts for that. And we'll be coming to the shortcuts themselves shortly. But risks of taking shortcuts are there, and we always need to take care not to overwork the patient, because essentially what happens when you overwork the patient, it goes wrong. It goes badly for them. There'll be an aggravation or a non-response entirely. And so managing the treatment to enable just the right level of healing is a tricky thing to do. And Most clients will respond into two types. So here we see acute patients that aren't likely to aggravate any more than they already are. So there's a fine balance to knowing when too much has been done. And I use their body temperature during the session to guide me. And when I say body temperature, I'm not taking out a thermometer and sticking it in their mouth and getting a reading every 10 minutes during the session. I'm actually using my senses of my hands to follow where the heat goes during the session. And it's a very simple observation that if you hold your hand over an area of the body that you're working, you'll see a change in the temperature of it. And I essentially work until the heat that arises from congestion in that area during the session, and I work until that dissipates. So let me give you an example of working on someone with a low back spasm again, because it's such a common issue, or even a chronic low back pain. So we've got a lot of tools in our arsenal for treating that problem, and I'm going to show you some of them towards the end of this webinar. So, for example, we start the treatment, we do BRMs 1 and 2, we return, we assess for heat over the kidney region, but we can also assess for heat over the sacral area or the coccyx or the glutes and decide where there may still be congestion. You can feel it up in the upper back, you can feel it in the hamstrings, behind the knee, anywhere in the body that you can attune yourself to follow, you can see a change in the temperature. Now, let's say I do a BRM 1 and 2 and there's still a little swelling evident by observation in the sacrum, but more importantly, there's heat in that area. What that means is that we've created a blocked area of congestion. There is a blockage there. The inflammation doesn't allow the flow that gets created from the Bowen treatment to move. And so we need to address that, and we want to select a procedure to release that congestion. So you may use a procedure called the sacral release, and I'll show that after the towards the end of the webinar, or you may use a procedure like gluteal release or Coxix oblique for that type of congestion. It really essentially means that or it could be Coxix that you apply. So you have to use the symptoms of the patient as a guide. You have to use the way they're responding as a guide and where the heat is exactly. If it's very one-sided in the sacrum, I might choose Coxix. If it's general over both sides of the sacrum, I might choose sacral release. If it's higher up above the sacrum into the lumbar, I might use Coxix oblique. So there's some very clear-cut locations of pain and inflammation that dictate the procedures we can use. So these are tremendously important in saving time for the patient. If you can address that congestion right there before it becomes evident in the days that follow a session, this is a very, very useful information. So chronic patients that come for remedial treatments are pretty common in my practice. There's a lot of clients that have ongoing severe chronic health problems, and they come for treatment to reduce inflammation, get their body moving, and give them a real pause where they feel good for a few weeks. And they may come, every month or something like that. And in those cases, it's a juggling act of how many procedures they need and how many procedures you can get done without causing aggravation. Okay, so moving on now. One of the most important aspects of Bowen therapy is that there's an issue of time, and that time is necessary for everything to happen when it comes to Bowen therapy. So we give pauses of time that can be much, much longer when we're working in an area of concern, such as the low back, such as the pelvis, such as the upper shoulders, and so forth. I give a lot more pause around the areas of concern, just logically. And sometimes there's a lot of heat in the area where we have a concern, and that is not necessarily a cue to do more treatment, but perhaps a cue to wait and to let the body process the treatment itself. We need to educate our clients about the need for time for the response after treatment sessions. And sometimes the effect of the treatment may be ongoing for several weeks, and we need to learn that that is possible, and that we must give time for it to respond. Okay, so let's go through a list of time-saving procedures, and we'll go through the a session where we're doing BRMs. If there's no low back problem that we're addressing, and we're only doing BRM1 as a general tonic, as a general nervous system, complete fascia treatment of the body to get the patient to really go into parasympathetic response, I'll skip after moves 10 and go directly to BRM2. So this saves 2 minutes, which is, when you add up a few 2 minutes in a session, you can save a bit of time and get more done. And but in light of what we talked about earlier, these are the procedures that I'd often do in and around BRMs 1 and 2. And these exclude the commonly taught procedures like the kidneys, the respiratory, the Coxix, and so on. So sacrum release is a treatment along the edges of the sacrum, as where the glutes attach to the sacrum. We can do a series of Bowen moves that release that tension. And this I think, is one of the most valuable procedures that were unfortunately taught so much later in the general training of Bowen therapists. There's a procedure called straight up the leg, which is a sort of backwards version of moves 5 to 8. And there's a procedure called hamstring light, which is a reversal of the moves 5A and 5 and 7A and 7, where we make a medial move over the holding point 5A and hold a point at 5. So it's a kind of a backwards version of BRM2, and I'll show those in a moment. And then Coxix oblique is a superior challenge and release of the lower margin of the glutes. So let's look at these. So in the top left, we can see the sacral release, where we make a series of moves along the lateral border of the sacrum on either side first. Generally, we do this on both sides. So I use 2 thumbs and take a little slack superiorly, apply a little challenge, and then move inferiorly along the lateral margin of the sacrum. So that's a wonderful procedure. You can apply it right at the very beginning of a session, or you can apply it during a session. Coxix oblique is often indicated in low lumbar tension. And what we need to do is landmark a midpoint between the ischial tuberosity of the femur and the pelvis, and then the tailbone, around where we do the Coxix procedure. And then we take inferior slack and make a superior challenge and release. And we do this bilaterally. So you're really gathering the inferior margin of gluteus maximus and some of the sacrotuberous ligaments beneath it. And you can actually do this on yourself, and you'll see you'll get a very strong release. If anyone of you remember the East procedure, where you take slack around the pectoralis major muscle on the chest, it's something similar to that. So we have to gather a lot of slack and challenge a very sensitive area of muscle. But if you do this well, you'll have great results. And then on the left is hamstring light, which is a reversal of the holding point and the move of moves 5A and 5. And of course, if it was on the right leg, it would be 7A and 7. So where we would hold 5A, we'll actually make a move while holding where we do move 5. And this is extremely useful because you can relieve the hamstrings of their tension in a very short time. So the other move that I tend to do quite a bit is the move straight up the leg, which is a way of releasing before you do a treatment session the hamstrings again. So it's essentially going in reversal of the traditional moves. And we start at the popliteal fossa at the biceps tendon and make a medial move, followed by the move on the iliotibial tract, and then the holding point 1A is done while we do move 1. And then move 3 is over gluteus minimus on the glutes, not maximus. So a little bit different there. So these I find are real shortcuts in terms of treating low back problems. And you know, you need to practice them to understand where they're applied, but don't be afraid to use these during sessions where you treatments. Okay, so other time-saving procedures we could look at are, you know, treating allergies when we have a sinusitis. We always think about the TMJ procedure. That's kind of a prerequisite for treating allergies and sinusitis. So under the eyes or in the forehead, I add the sinus procedure immediately after the TMJ. So it's a kind of an additional step. If the emphasis of the problem of allergies or sinuses is in the jaw, then I'll wait and see before applying the sinus procedure. And wait and see means waiting a whole week of the visit. So this is the procedure itself. Moves 1 and 2 are first they're medial and then inferior moves over a midpoint on the eyebrow, and that's the superior margin of the orbit of the eye. Move 3 is on the under the eye and on the superior margin of the lower orbit. So it's not on the cheekbone, it's inside in the orbit of the eye. So part of your finger when you do the move actually touches the eyeball, and your pressure is inferior towards the feet. So it's both of these, 1, 2, 3, and 4, are all sensitive areas. Moves 4 and 5 are over the very last corner of the sinuses, but this is on the cheekbone, the lower corner of the cheekbone. And if you press it, you should feel the sensitivity there. So I'll be posting a handout of this on the website next to the video, so you'll get these pictures and see where they are. These are all in the manuals 7 and 8, and so that's another way to get the information. Okay, so another important area of concern are shoulder problems, and you know, when and how can we cut corners or speed time or make the efficiency really much more for the patient? So one of those is just choosing when to do the shoulder first visit. And, I measure the acuity of the situation along with the vitality of the patient. So the more acute and vital the patient, the more likely I'll be doing the procedure. But if there's been a chronic problem, long-lasting shoulder pain, I'll be more careful and wait and see what changes after one visit for this patient. Now, in doing shoulder procedure, there may be a tendon that is not addressed with the basic shoulder procedure, and the most common is actually the mid-deltoid, which is where we do move one of the elbow procedure. So there is a procedure that I will do that addresses those tendons that are very likely injured in a shoulder procedure, especially when you assess for the north procedure and it is showing that it's needing to be done. So move one of the move one over the mid-deltoid is the move one of the elbow procedure. And if I do that followed by 3 moves over the biceps tendons at the top, so we can see the long and short head, plus what's deeper to those tendons, the coracobrachialis muscle, and I'll make a strong move over those 3 tendons. This is a little bit different and deeper than move 3 of the shoulder procedure over the anterior deltoid. So here we're going a little bit deeper. I want to get all 3 structures, so the muscle deeper to those 2 long tendons of the biceps. And then down towards the elbow crease, we'll make a move over the biceps, and then in the mid point of the arm over the meaty part of the biceps. So these 3 moves preceded by move 1 of the deltoid, and followed by, also preceded by the basic shoulder procedure, will cover a significant range of muscles that are probably part of the story of a chronic shoulder problem. And I find this a big time saver. In traditional Bowen therapists training, we're told to wait a month between shoulder treatments. And, that can really work against the patient. And, this is a way of helping them move faster. If for any reason you do aggravate the shoulder, of course, they're going to have to medicate to get through it and or apply anti-inflammatory creams and so on. But don't feel disheartened. The next visit, slow down completely, and you'll recoup the situation. So, it may aggravate even with less treatment than this. So, I feel it's a worthwhile risk. And but again, be careful who you apply it to, and make sure that they're not emotionally loaded at the time that you do the treatment. So here's a couple of other areas we can address, and we talked about sciaticas and lumbar disc hernias. They're pretty much the same, and that's the follow heat during the treatment. Consider other procedures like sacral release, like gluteal release, like Coxix oblique, and straight up the leg, hamstrings light. Also consider the options of doing the Coxix more quickly than you would have been comfortable doing before, based on the symptoms that are addressed. And then also consider pelvic and sacrum whenever there's misalignment of that the foundation of the vertebrae is the sacrum, the way it sits inside the pelvic. Bones dictates how the rest of the posture goes and how the muscles have to function above it. So that really does need to be addressed. And it's very easy to switch off the inflammation in the muscles with basic Bowen therapy, BRM1 and 2. but to correct the alignment of the sacrum is really our goal, and we want to use pelvic and sacrum to achieve that. Now, treating migraines, it's pretty straightforward. I'm going to look at where is the congestion, and most likely it's in the head. If it's not there, I'll know after a visit or even a second visit after that, and we'll apply option B, which is the Coxix procedure. So when I say look for migraine congestion in the head, I really mean BRM3, upper respiratory, and TMJ. And the other alternate treatment choice is essentially Coxix procedure. There are other options involving shoulder and so forth in treatment of migraines, but go one step at a time, and you'll save a huge amount of time. In treating frozen shoulder, yes, someone who responds easily to the treatment, you might go every 3 weeks to do a pair of treatments, but it does take time to repair. It's just a question of how quickly do you set it on that track of getting better. So if you're finding that even after a month of treatments, the shoulder is not responding, chances are you can do something to move that story further ahead. So I really do encourage adding in elbow procedure move 1, which is also part of North procedure, also part of elbow, and that biceps procedure I talked about. Allergies and sinusitis. Another area that you have to consider is how to get the immune system if there's an infection in the sinuses causing the inflammation, and that may be an area that you need to address as well. In treating bunions, you can watch the videos relating to that, but soaking the bunions is especially important, and getting the client to do the procedure themselves. It's absolutely vital. That's why I have the video online. It's not just for students of Bowen therapy, it's also for patients. Here's one that's quite interesting, the Achilles tendon rupture. How can we repair that more quickly? There is a procedure called burning heel that I would apply after the hamstrings whenever there's a new or old Achilles rupture. Okay, wonderful. So I hope this has recorded and people have seen it. And I also hope that you enjoyed this webinar. If this was successful in the setup, I'll also be what can I say, adding in a live component and doing some demonstration at the same time. If it wasn't successful, I'll repeat it again soon. So I've kind of mumbled my way through this, but hopefully it was great for you. It was great for me, and we'll talk to you soon. Oh, I think I can switch over to the camera and say goodbye properly. So thank you so much for attending or listening, and take care and be well. Bye-bye.